Alex, thank you. All right, dear friends, so we will continue, not wasting any time, because we would like to hear everyone. And the next one is the head of the Prytime Medical Devices Chief, Akrish, REBOA and Modern Warfare, how extended occlusion times are defining a global way forward. You're welcome.
Hello, I'm Eric. I work for Prytime. I'm one of the military clinical educators, and I just want to thank everyone for having us here. It's a pleasure to be here. It's an honor to be here, an honor to help. I'm going to be speaking about REBOA and modern warfare and how I and we believe extended occlusion times are defining a global way forward, and we'll dive into that just a little bit. So I do have some disclosures. I am employed by Prytime as a clinical educator. I'm also a practicing clinician in critical care and emergency trauma nursing. We at Prytime here have made 6 trips total to Ukraine, over 45 working days in far forward locations, 10 cities, 20 hospitals, and trained over 500 physicians and probably 20 surgical teams at those forward areas. To date, we've given over $100 million worth of $1 million worth of training, equipment, catheters. We were also officially asking the U.S. government to formally add REBOA to the non-lethal aid package being provided to Ukraine. So who is Prytime Medical? What we do? We're the world's leader in resuscitative endovascular balloon occlusion of the aorta, which is REBOA. Our catheters are currently used in over 450 civilian and military hospitals across the globe. Our mission statement is no one should bleed to death, and the sooner you stop the bleeding, the better. We recently released the first partial occlusion balloon catheter. It's currently being used in Ukraine, and the catheter can give significant extended occlusion times of 4+ hours. The extended times can be used to significantly support transportation times, as well as getting patients from one area to another in an evacuation situation. The new catheter has been used over 500 times in civilian cases and 25+ times that we know of here in the Ukraine. So why does it buy you time? Basically, the partial occlusion catheter still allows blood to flow past where the balloon is, and it gives you time to continue to perfuse the end organs and below the balloon level. In the States, we're seeing partial occlusion times that are extended, more zone 1 occlusions of the 2 zones that you're supposed to occlude. This gives the physicians the ability to be able to transverse the hospital, essentially, going to CT to get a more definitive picture of what's actually going on with the patient. Also, a significant reduction in acute kidney injuries compared to the previous REBOA technology. So when we first came here, we kind of started at the west and worked our way east. And as we worked our way east, we found that the more the surgical teams that we trained further east, the more beneficial the catheter seems to be going back west. And what I mean by that is the catheters being put in at stabilization points and transversing the evacuation with the balloon inflated partially to be able to get to definitive care. And of the 25+ cases, I know distinct details about 10 of them, and all 10 of those patients came from the point of injury to the stabilization point and made it out to a more advanced medical treatment facility. The transportation of patients with the balloon in at partial occlusion is something that's only happening here in Ukraine, and it's very fascinating. Something that I think is going to help educate the rest of the world on how and when to utilize the catheter. So I'll speak very briefly on this since we are in a war zone. Military large-scale combat operations, the peer-to-peer aspect of this is what the U.S. military, I believe, is very involved in, NATO very involved in, things that we really want to try and figure out and why we are partnering with all the countries to try and figure this out. So what is it? Very modernly, or very minutely speaking, modern large-scale combat operations is just a state or country-wide situation, peer-to-peer, where every bit of life has some type of insult, not just on the front lines, but throughout the entire country. So what we're used to in NATO is the golden hour evac, which we're seeing here is not actually something that can happen anymore. Point of injury to treatment facility can be a lot longer than 60 minutes, which is where our catheter comes into play. So a little bit about austere medicine and what we have been doing. As I stated, we've made it pretty far east, giving training, giving point-of-care ultrasound training as well, and giving REBOA training to full surgical teams in order to help them utilize the catheter and utilize the surgical technique better and more proficiently. Limited to no advanced resources, no immediate resupply, incoming indirect fire, and dated or sometimes no equipment whatsoever. So as we made it across and we started training the very far east, close to the front lines, we realized that the surgical capabilities were actually better than, at least I assumed they were to begin with. So I'll go over one case and then I'll take questions, trying to speed along here. So 34-year-old patient, this is a very recent case, just a few weeks ago now. 34-year-old patient struck by artillery fire. There's time hacks on there as well, 12:40 p.m. and then 14:10 arrival to the stabilization point. The blood pressure on arrival was 60 systolic. They placed, intubated, and fasted the patient. Noticed there was blood in the abdomen, but the heart and thoracic cavities were clear. Also to note, a large left buttocks and thigh wound. It had massive amounts of bleeding. Differential diagnosis for this patient: gunshot, mine explosive trauma, polytrauma, abdominal and ortho trauma, internal abdominal bleeding, pelvic trauma with partial fractures, left full femur fracture, and hypovolemic shock. So initially, gel span infusion was ensued. They did some massive transfusion protocol totaling around 1,800 cc's. 2 amps of calcium, some antibiotics, and some sedation were given. They also prophylactically inserted a 7-French sheath into the right femoral artery in preparation for future resuscitation. 14:23, this patient lost pulses. They did 1 round of CPR, gave some adrenaline, and the patient shortly after that got ROSC achieved, spontaneous circulation achieved. The blood pressure post-recess was okay at 110, then it kept dropping 90 and 60, trending downward. They put in a REBOA catheter to zone 1, inflated the balloon. The blood pressure rose to 118 systolic and increased on the Compass device, which is a small device that they also utilize to monitor the mean arterial pressure. While this was going on, the team fixed the rest of the lacerations, or at least prepared for transport. The patient then was transported an advanced ambulance transport with the same physicians monitoring during the entire evacuation process. And during the transportation, the balloon was manipulated multiple times to maintain hemostability. Total transport time was about 29 minutes. At this time, when the patient got to the next level of care, they went to partial occlusion, and it was maintained until they got to the OR. So in the OR, the findings: pelvic damage with retroperitoneal hematoma, fracture of pelvic bones, multiple areas of damage in small intestines, and then again, the large laceration and wound, left leg, and femur fracture. Once stabilized, the balloon was moved to zone 3, still at partial occlusion, to help mitigate the pelvic bleeding that was happening. Once they gained hemostasis, they took the catheter and the sheath out without any issue. They did note a small thrombosis in the right femoral artery, but it was repaired without issue, and then the patient was evacuated to the next level of care. During the procedure, the entire procedure from stabilization point to the evacuation to the next level of care, the balloon was inserted at zone 1 for 29 minutes to include a little bit of partial, and then zone 3 for 21 minutes, all partial, with the last 3 minutes of no occlusion at all, meaning they took the balloon completely down because they achieved hemostasis. Total balloon uptime was 50 minutes. They did give some calcium bicarbonate at the 40-minute mark to mitigate a little bit of acidosis. And the output of this patient over the entire care continuum was 200 milliliters, and they were on and off vasopressive medications to support life. So in conclusion, what we're seeing in Ukraine, what you guys are seeing in Ukraine, is there is a clear benefit to be able to put partial occlusion catheters in patients and be able to transfer them to transverse the evacuation landscape. Extends the safe occlusion time over 4 hours and allows transfer from stabilization point to the different roles of definitive care. It also reduces blood product usage and provides a resuscitative adjunct as well as a blood pressure adjunct to attain hemorrhage control. And that's it.
Thank you very much. Thank you for your work, for your position, for your experience, and for sharing all this with all of us. Does anyone have questions?
Oh.
Yes, please, Костянтин. Можна мікрофон, будь ласка.
Знаєте, в мене тільки є слова щирої вдячності. Тут є команда Кріса,
Thank you a
Еріка.
lot. This is Chris's, Eric's team. Thank you so much. These are partners who were first in Ukraine, who helped us to implement REBOA system in Ukraine. I would like to tell you that the trainings that you've provided to give REBOA in Ukraine saves our soldiers' lives. So thank you very much for our cooperation, our collaboration. Hopefully, we will continue to save our soldiers and people. Thank you so much. Thank you, Konstantin. More questions? I also would like to thank on behalf of all the Ukrainians, thank you so much that the technologies are developing and the knowledge of our doctors are developing and saving the lives. Thank you.
I have a question because this technology is really new for us, and not many doctors or especially combat medics know about this device. And I ask you, what time limitation we have to use this balloon, and can we use some short time deflation to check about source of bleeding in the evacuation stages?
So, excellent question. The whole benefit of the new catheter that you have here in Ukraine is that you don't actually have to do intermittent occlusion to be able to see where you're bleeding. You just partially occlude the balloon. A lot of people are going to full occlusion and then backing down a little bit to partial, and that way they still increase hemostasis above the balloon, and below the balloon they're able to still see. It still gives you relatively dry field, but it also gives you the ability to find out exactly where you're bleeding.
Thank you.
Yeah.
Дякую дуже. І ще одне.
Thank you very much. And another question. We have for one more, but we don't have any questions.
Дякуємо дуже. Дійсно.
Thank you very much. It's a huge help to Ukraine, to our friends and partners who help us to win and to save the